will be discussed, including antidepressants, mood stabilizers, antipsychotics, sleep medications, as well as medications used for the treatment of substances of abuse. The presentation will be interactive and will include a question and answer session. I know that a lot of people have submitted their questions in advance, and that's great. Dr. Alipour is an assistant professor in the Department of Pharmacy Practice at Marshall B. Ketchum University College of Pharmacy. Before that, she was psychiatric pharmacy faculty at the Ernest Mario School of Pharmacy at Rutgers University in New Jersey. Azita is a board-certified psychiatric and geriatric pharmacist. Her academic and professional degrees consist of a BS in psychology and Doctor of Pharmacy. She completed a postgraduate Year 1 pharmacy residency and a postgraduate Year 2 pharmacy residency in psychiatric pharmacy. As a psychiatric clinical pharmacist for Kaiser of the Mid-Atlantic States, she received a Service Excellence Award, 3 Customer Service Awards, and a Pharmacy MVP Award. Her current practice site is at St. Joseph Hospital in Orange, California. Dr. Alipour's areas of interest and expertise include mood disorders and addiction and substance abuse. Let's welcome Dr. Alipour. But before I do, I just would like to ask everyone to turn off your video so that Azita has the full screen to do her presentation. Thank you.
Thank you so much for the introduction. I'm going to just go ahead and share my screen so you guys can see my slides. All right, can you see my slides? Is that a yes? All right, so fantastic. Thank you for the thumbs up. Awesome. All right, so let's go ahead and get started. I want to thank NAMI-Santa Clara for having me as a guest speaker tonight. I am very excited to be here to speak to you about medications and to be able to hopefully have you guys take away some tips that will help you take your medications more effectively. And we're going to go into some other things about how to have conversations with a doctor when you get that limited time with them, to be able to maximize the appointment. And hopefully you'll learn more about other medications so that if they do bring up options, you've heard of those options before, or you can bring up additional options that maybe the doctor hasn't brought up that you've heard about on this presentation. So before we get started, I would just like to state I don't have any conflicts of interest or anything to disclose. And we will be speaking about off-label uses of medications because a lot of what we do in psychiatry is off-label use. So we will be speaking about off-label use of medications. So today we're going to go over how to maximize that time with the doctor, be able to understand how the medications work and what to expect. Go over some special considerations with specific medications. What are some side effects that are of concern that you should know? And what are some common side effects that you might expect? And the importance of taking your medications is going to be reviewed as well. So here, some questions when you guys are going and you're having that appointment with a psychiatrist or with a primary care doctor that's managing your medications used for mental health is that think about asking them when they prescribe a medication, what am I using the medication for? And this is because these medications, they're used for so many different things that it's always important to ask the doctor what they are prescribing that specific medication for. I'll give you guys an example. I think most people have heard of Seroquel. Okay, Seroquel is the brand name, the generic is quetiapine. And that medication is classified as an antipsychotic, but it's used for so many different things. So it could be used at very low doses to help with sleep. It could be used as a calming medication. It could be used to help if somebody is hearing or seeing things that are not there, or it could be used to help stabilize the mood. So if somebody has very high moods or low moods, to kind of keep the mood nice and even. So there's a number of different things that medications can be used for. So it's important to know, what am I taking this medication for? And then what can I expect from taking the medication? So that's also something very important to ask the doctor, because when you first start taking a medication, you want to know, when I started, what are some common and some serious side effects associated with the medication? And then,
sorry to
yeah.
interrupt you. The slides are not moving.
Oh, they're not. Oh,
Yeah.
hold on 1 second. Let me go back. Sorry about that. Let's see. Thank you for letting me know. Oh, I think it's read only. Okay. Slideshow. Let's go here from current slide. Okay, let's see if it'll move. Is it moving now?
Yes.
Okay. Okay, awesome. Okay, thank you. Thank you for letting me know that. So,
Yeah.
so it's important to know, how soon will I start noticing the medication working? For example, what symptoms might it help me with initially, and then what symptoms will it help me with that might take a little bit longer? And that's because sometimes when we start a new medication and you're like, well, it's not doing anything for me, right? But you might not realize that, the underlying mood or the underlying depression from starting that antidepressant could take 6 to 8 weeks to start having full effects. Initially, you might start noticing improvement in sleep, appetite, energy that first week or so, but the underlying mood can take a while to see the full effects. So it's important to know those things so that, we don't give up on the medication too quickly, that we can kind of know what to expect. So, all right, so let's go into antidepressants. Before we do, there's the 9 different symptoms of depression. So depressed mood, usually sleep most people present with problems falling asleep or staying asleep, but some people can present with the opposite, where they're sleeping too much. Can have a decreased interest or pleasure in the usual activities, feelings of guilt, having low energy, problems concentrating, having little appetite, or in the opposite case, which is not as common, is too much appetite. And then could have thoughts of hurting yourself or others. So these are just some different symptoms of depression. I want to go over those because we're going to go over how the antidepressants can help with those symptoms. So I just talked about how, you might not see the effects on the underlying mood from the antidepressant right away. And that's because, if we look at kind of the theory behind how depression occurs, it's thought to be a neurochemical imbalance. So the 3 different neurochemicals, we'll call them neurotransmitters, that are thought to be involved are serotonin, dopamine, and norepinephrine. So the way that we send messages and communicate is through things called neurons. And then these send messages at lightning speed. And the way that one neuron communicates with another neuron is they release these things called neurotransmitters in between the 2 neurons. And so that connects to the next neuron and sends the message along. So one of the theories in depression is that there's so little, for example, serotonin, dopamine, or norepinephrine, that you get a change in the underlying physiology there. So what the antidepressants do is they actually increase the amount of neurotransmitter, a lot of them, between the 2 neurons, so that things can go back to normal. So because of that, the antidepressants, they don't work overnight. That takes time. So that's why it could take 6 to 8 weeks to see the full effects of that antidepressant. So if we look, there's a number of different antidepressants. We got the older antidepressants, things like our tricyclic antidepressants, like if you've heard of Elavil, and then we have a newer ones. So we usually the first go-to is the newer antidepressants because they have a lot less effects on causing confusion or things that we call anticholinergic, where they can make you confused. So the newer ones are thought to be a lot better tolerated. So those are our first go-tos. And usually the class of the go-tos that we usually the doctors go to first are the class selective serotonin reuptake inhibitors. So these work just on serotonin, right? So sometimes depending on how each person responds, a doctor might, if you're partially responding to one that works just on serotonin, they might add something like a Wellbutrin to kind of give a stimulating effect, or they might add on something like a Remeron or switch to them. So they're looking at all the different aspects of how it becomes very specific to the person, you know, about your response and how we can tailor the different medications to fit your specific response. In general, they're supposed to be equally effective, the antidepressants, but in reality, that's not the case. Each person responds differently. So what worked for you may not work for another person. So each of us is different in how we respond. If you have a family member, a first-degree family member, let's say your mom, or you have a sibling that did well on one of the antidepressants, then it may be likely that you might be more likely to respond to that antidepressant. So that's good information to give to the doctor if you have like an immediate family member that did well on one of them. Because otherwise they just look at, okay, so what are your target symptoms of depression? Are you mostly feeling tired during the day? Then they might give you a stimulating antidepressant, like something like a Prozac or something like a Wellbutrin that'll give you more energy during the day. And that's why those are not taken at night. So they take them early in the morning because then they would keep you up at night. If the problem is a lot of, you know, you have problems falling asleep and you have depression, then something like Remeron here, this one can help with appetite, and it can also help with sleep and depression. So the doctor looks at a number of different things when they're deciding which antidepressant might be best. Sometimes a lot of people who have pain, depression also goes hand in hand with that, and they kind of feed into each other too. So if you have a pain condition and you have depression, then a medication in this family called serotonin norepinephrine reuptake inhibitors, these can actually help with pain conditions and they can help with depression. So something like a Cymbalta or an Effexor might be an option that the doctor would look at to see, you know, I can help with your depression and your pain with that medication. The medications that help with, that work on serotonin, a lot of them help with anxiety as well. Okay, so they can help with different anxiety conditions. So it's a win-win if we're treating anxiety and depression to start like one of them that's in this category, like a Zoloft, for example, or an Effexor in the SNRI category. So we look at a number of different things when deciding what might be a good option to explore. And unfortunately, sometimes we have to try a couple different ones before we find the right one that works for the patient. Okay, so first line options we talked about are the newer ones that they use. So the time of onset of effects, we talked about that too. Within the first couple days, you might notice you're sleeping better, your appetite is improved. Within that first week, you could have improvement in your energy. If you had a decreased sex drive due to the depression, they might see that improve as well. But it could take up to 6 to 8 weeks for that full relief of the depressive mood to occur. So being a little patient with that at that dose that you're on. The doctor, when they started to, if you have a anxiety with the depression, they need to just be a little bit more careful about how they're dosing it, because even though a lot of the medications that help with depression can also help with anxiety, if they start the dose even sometimes at a normal starting dose, some people, if you have anxiety along with it, it can actually make you more anxious. If even at a starting dose. So sometimes because of that, the doctor might be a little bit more conservative with the starting dose so that it doesn't make you more anxious. And if you do notice you're getting more anxious after starting the antidepressant, let the doctor know they can decrease the dose or what to do. They might give you a medication to relieve the anxiety while you get used to the medication. Okay. So antidepressants can cause sexual side effects. So that's just something to be aware of. Maybe pharmacists might not have counseled on this. But if you do notice that you've had a worsening and anything related to that after starting the antidepressant, let the doctor know there's options for that. So they can look at, you know, are you more appropriate for a medication that has a lot lower risk, like Wellbutrin, which is bupropion, or Remeron. So there's different strategies. So don't be afraid to speak up and let the doctor know if that occurs. So antidepressant withdrawal effects. So, you know, anytime you start a medication, your body's going to, you know, when you've been taking it for a while, your body's going to be used to it, right? So if you take it away, you can have withdrawal side effects. The withdrawal related to antidepressants is more like flu-like symptoms that you can get, like fever, chills, sweating. You can get brain zaps. It can be really uncomfortable. With antidepressants, it's not like benzos are life-threatening, right? Benzodiazepines like Ativan or Valium or those, if you've been on those for a while, you never stop those abruptly, because with benzodiazepines, you can have seizures if you stop abruptly. Antidepressants are different. So it's not like you're going to have a seizure stopping an antidepressant abruptly, but you can be really uncomfortable. So the doctor slowly tapers the antidepressant down. So if you're on a Lexapro or a Zoloft or one of those, they'll probably keep cutting the dose until they get it down and you're able to get off of it. If you notice at any point you're starting to have withdrawal symptoms when they're taking you down, then you they basically will taper it slower. So you would let the doctor know. So these are just some of the different target symptoms of depression we talked about. So if you're having a lot of problems with sleep, we talked about mirtazapine, which is Remeron, might be a good option. Trazodone is a medication I think a lot of people have heard of. Trazodone, we don't really, it's an antidepressant, but we don't use it for depression. We use it just as an add-on to help with sleep. And the reason is that the doses to help with depression with Trazodone, it's not tolerated at all. So we use it at lower doses to help with sleep. So that might be something that some of you have had before. And then with poor concentration, I believe it went to that, we can't see it. So bupropion is actually one that is used, bupropion is Wellbutrin. It's used off-label in kids to help with ADHD. So it can actually help some with concentration. And then with low energy, fatigue, something like a Prozac, which is fluoxetine, or bupropion, which is Wellbutrin, can actually be more stimulating and help with that. And then lack of appetite is Remeron and Paxil tend to be the two that can help with lack of appetite out of the antidepressants. And so we already talked about these. I'm just gonna skip through. Before I do though, there's a breast cancer medication called tamoxifen. So it can have an interaction with some antidepressants. So what happens is that some antidepressants can prevent tamoxifen from being broken down to its active form, meaning that with some antidepressants, it doesn't work. So that's just not good because it's a breast cancer medication. So if anybody's on tamoxifen, the doctor, some of the safer options are that wouldn't interact with, wouldn't have a drug interaction with the tamoxifen, or something like the Lexapro or Celexa, for example. So just making sure to include, because I did have questions about drug interactions in the pre-thing, so I wanted to make sure we covered those. If you are a smoker, Wellbutrin is an antidepressant that can be used to help quit smoking, and it's an antidepressant. So I just wanted to put that out there. All right. So some of you, when you went to pick up an antidepressant, maybe the pharmacist told you about serotonin syndrome. I hope you didn't get scared. It is extremely rare. So I wanted to just put this picture up here. It is very, very, very rare. Usually it's due to when you're on multiple different things that affect serotonin, it can increase the risk of getting something called serotonin syndrome, because we don't want too much serotonin either. That's not good. So some of the symptoms of serotonin syndrome are, you know, if suddenly you feel like you're confused, you can't coordinate your movements, your fever, your temperature is going up, your vitals, meaning blood pressure, everything is going up, you're sweating, you got these belladonna eyes, and then one of the biggest indicators is this lower leg tremor that you could see in that picture. So, and you have to be on something that affects serotonin to get serotonin syndrome. So It's extremely rare. So I wanted to just let you guys know that. Sometimes the pharmacist might scare you and say, oh, you're trazodone, oh no, with your antidepressant, but it's okay. That's something we commonly do. Okay. And then antidepressants do carry a boxed warning for suicidality, but this is more the difference, even though it's supposed to help it, maybe some people might have an increased suicidal thinking from an antidepressant. So I think you've probably seen this on the medication guide. The risk is for adults 24 years of age and younger. So young adults, adolescents, and children is where the studies show that might be at higher risk. So I wanted to put this question out there. Think about this. So can you become addicted to an antidepressant? So, you know, when I used to do outreach for patients staying on their antidepressants, one of the things I would hear back was, you know, I stopped my antidepressant because I thought I would become addicted to it. And I wanted to tell you guys that no matter how long you are on an antidepressant, you cannot become addicted to an antidepressant. It is not a controlled substance. So it's really the difference between addiction and dependence. With anything, once you take it, your body gets used to it, right? So when you stop it, you can have withdrawal effects, but that's different from addiction. So addiction is more of what we think of connected to a psychological thing. So for example, somebody who is addicted to a substance would stop at anything to attain it. So we think about, would somebody stop at anything and do something illegal to attain something like a Lexapro, which is an antidepressant? And the answer to that is no. So no matter how long somebody is on an antidepressant, they can't become addicted to it. It's not a controlled substance. And I think I'm getting some, I see that, you know, the orange box keeps popping up. So I will make sure we address questions that come at the end. So I just wanted to give you guys an update because, you know, for a lot of us, we see that, you know, you try one antidepressant, you try two, maybe they're not working, right? So the doctors have, you know, evidence-based options to try. So on top of the antidepressant, they might add a medication from a different category. Lithium is used as add-on to help with depression to the antidepressant. Lamictal is used as add-on to help with depression. Actually, antipsychotics are added as well. So we have different ones like Abilify is added, Seroquel. So there are a number of different options, and we'll go through like some of the side effects of those in a minute. But I don't know how many of you have heard of this new medication. It's called Spravato. It's S-ketamine. Ketamine has been around for a very long time, right? When you think of ketamine, some people think of a club drug. So this is actually a more active form of ketamine, S-ketamine, that was recently approved. It's the off-label. People have been doing ketamine infusions, which don't really have the evidence behind them. But this new medication is a nasal form of the active form of ketamine, more active form S-ketamine, and it's approved in addition to the antidepressant to help with treatment-resistant depression. And treatment-resistant depression means you've had at least 2 adequate trials. By adequate, I mean you've had a therapeutic dose and you've been on it for at least 6 weeks. So if somebody is treatment resistant and, you know, other options, let's say ECT is not an option, which is electroconvulsive therapy, Spravato is something that just got approved. So this is another option that's out there. So some of the side effects with Spravato is, you know, you can have dissociation. This is one of the biggest things, sedation, and it can affect the blood pressure. So these are some of the reasons that Spravato isn't something they dispense for somebody to get in the pharmacy and take home with them. They basically have to come into a clinic that is a Spravato clinic, and they have to come there. They can't drive. They sit there for at least a couple hours while they've gotten it administered to be observed for these side effects. And if they're not having the side effects once they're feeling well, somebody can drive them home and take them home. It's a medication that when somebody starts it, they have to go in and get it at least twice a week, and then it could be once a week after that or every other week. So it's something that requires a lot of time to be able to do that. But it is an option that is brand new. It's a brand new mechanism compared to the other antidepressants that we have there, or other treatments that we have as add-on. So now we're going to shift gears and go into antipsychotics. So some of the target symptoms that we have with antipsychotics, these are basically calming us down, helping with sleep, as we talked about. Seroquel tends to be one of those, helping with suspiciousness, ability to, if you're hearing or seeing things that are not there, or fix wrong thoughts that we might have. So response time within that first week, you might get improvement in agitation, aggression, sleep. At 2 to 4 weeks, it could take 2 to 4 weeks to see some effects on hallucinations, paranoia, and delusions can take, which is a fixed wrong thought, can take 6 to 12 weeks. And then you could take anywhere from 3 to 6 months to have improvement with cognitive symptoms that we might have. And then antipsychotics can also have discontinuation effects. So if you see here, some of these look like some of those flu-like symptoms that we're talking about, like nausea, vomiting, diarrhea, cold sweats, muscle aches and pain, feeling anxious, confused, and problems with sleep. So we have our older generation and our newer generation antipsychotics as well. So with the older generation, these tend to have more side effects related to movement side effects. So what I mean by that is there's a couple of different movement side effects related to antipsychotic, and they depend on how strong they are at blocking something we call the D2 receptor. So these older generation ones, especially ones like Haldol, for example, are more likely to cause movement side effects. So one of those movement side effects can be like looking like you have Parkinson's when you don't. One of the other ones can be like this thing we call akathisia, which is like a inner restlessness, like constant need to be moving, feeling like you're going to be jumping out of your skin. And a medication, and one of the antipsychotics that's more likely to cause that is Abilify. So we have a number of different movement side effects that can occur. Another one is something we call tardive dyskinesia, which is, it looks like worm-like movements of the tongue, for example. So these are just classing them based on how strong they are at the D2 receptor. So Haldol, flufenazine, which is Prolixin, those tend to be stronger at that D2 receptor, and they might have more effects on causing side effects. And these are just some pictures of what these different movement side effects might look like. So if you see the feet in the chair, that's that inner restlessness, feeling like you got to be moving around. And then if we look at the timeline, these newer ones, Clozaril is the one that came out in 1990. So one of the big things about Clozaril is, so antipsychotics, they're supposed to be equally effective, okay, for schizophrenia, for example. But the only one that's been shown to be superior to the rest for treatment-resistant schizophrenia is Clozaril. And Clozaril is one that, even though it could be superior in that case, we really reserve it for, it's not a first go-to. It's more of like you failed other ones, or you're treatment resistant at some point, and then that's an option that you're getting, because it has a lot of side effects that can occur with it. So we don't go to it as a first go-to medication. It can affect white blood cells. It can cause something called agranulocytosis. It's got one of the highest risks for causing the weight side effects. So there's a number of different reasons why Clozaril tends to be one that, even though it might be a little more effective compared to the others, we don't go to it first. But it is a good option to have and keep in mind if somebody is a good candidate for it. So when is clozapine, which is clozaril, indicated? So we talked about treatment-resistant schizophrenia. So if you failed at least 2 adequate trials of antipsychotics, it may be an option. The problem with clozaril is because of the risk for agranulocytosis, it requires blood monitoring. So that can be a barrier to someone from being able to get clozaril, because you actually have to be able to go in for the first 6 months, at least every week, and be able to get the blood work. So they check it to just make sure, because the risk for agranulocytosis is highest at the very beginning, and it decreases over time. So that's why the first 6 months that somebody's on clozaril, they check they check the absolute neutrophil count at least weekly, and then the next 6 months they check it every 2 weeks if everything's normal, and then if everything's normal after that, after a year, it's monthly unless something is abnormal. So because the risk has decreased at that point, so the monitoring goes down. But because of the monitoring, somebody has to be able to be willing to do the monitoring to get it. It can also be actually really good if you're having for suicidal thoughts and for aggression as well. So this is another thing that usually comes up, because we talked about the older antipsychotics have more risk for causing the movement side effects. The newer antipsychotics have less risk for movement side effects, but their big thing is the risk for causing a metabolic side effects, meaning by causing weight gain, and a lot of the times the weight gain might be more in the stomach area. So when that happens, it can lead to blood sugars going up, blood pressure going up, and cholesterol going up. So because of that, it's one that we look at, clozaril can have the highest risk, Zyprexa can have within the antipsychotics. So there's ones that can be more weight neutral. So like a Abilify may have less risk for weight gain. Latuda, Seroquel, Risperdal are more in the middle for weight gain. Not everybody gains weight, but in terms of why it happens with those medications, well, they don't fully understand it. It could be due to a number of different things, but just to not get so technical with you guys, I could tell you just from when people are on the antipsychotic, one of the things I traditionally hear is, I'm getting the munchies. Like, I'm craving carbohydrates, I'm craving sweets, I'm craving fatty foods. So that can be one of the mechanisms that somebody is gaining the weight, because you're getting these cravings, and then if you're not making the healthy decisions and giving into the cravings, it can cause the weight gain. So I usually tell my patients, like, if you're craving like ice cream, maybe like a frozen banana with like blended with other fruit or something might be a healthier option. So try to make healthier decisions if you're getting those cravings. And then there are some medications that, if somebody does end up gaining weight, and one of the things the doctor can look at is if they have to stay on that particular antipsychotic, there's different strategies. There's some medications that they can actually possibly add on. Metformin's been studied. Sometimes Abilify's been studied. Topamax, topiramate has been studied. So there's a number of different things that they've looked at. But one of the most effective things is obviously diet and exercise are actually really good. If you're on these medications, if your doctor allows you to exercise, and then watching what you're eating can make a big significant difference as well. So if you guys have heard of Latuda or Geodon, it's very important to note that these two specific antipsychotics have very specific calorie intake requirements, meaning if you don't take Latuda with at least a 350 calorie meal, or Geodon with at least a 500 calorie meal, you're not going to absorb the full dose of that medication. So with Latuda or Geodon, if you're on either of those, to get the full benefit of that dose you're taking, you need to take it with a specified amount of meals, with at least that much. So basically taking it with a real meal will help you with the absorption. So next question is, can antipsychotics be used as mood stabilizers? So, you know, when we think of a mood stabilizer, you know, we talked about, for example, in bipolar disorder, we have the very highs and then we have the very lows, right? So we don't want to go all the way up to the very highs, which is mania, because then you're a threat to yourself or others, because you might be partaking in risky behaviors, for example. You might be very irritable at that point, or the very lows looks just like depression. So we want the mood to be nice and even. When we say mood stabilizers, we think of the traditional mood stabilizers like lithium, which is the gold standard we think of. Depakote is another, Tegretol. But antipsychotics such as Seroquel, Abilify, Risperdal, any of those antipsychotics we just talked about, they actually can be used as mood stabilizers. So sometimes for bipolar disorder, the doctor might just have you on an antipsychotic, or they might have you on an antipsychotic and a traditional mood stabilizer, which is fine as well. So each person is going to be different with what they need, but the antipsychotics can be used as mood stabilizers. One other thing I wanted to tell you guys, when we talked about antidepressants, so antidepressants was like a Prozac, Zoloft, Effexor, Cymbalta, for example. Antidepressants are not mood stabilizers. Antidepressants can actually switch you from a depressed mood to mania. So they're not good. So usually in bipolar disorder, the only time somebody is on an antidepressant is if they're on a mood stabilizer, because the mood stabilizer will keep the antidepressant from switching you to mania. So we try to avoid antidepressants in bipolar, but we add an antidepressant sometimes, and we only usually do that if you're on a mood stabilizer in terms of as providers, these meds. So what is a mood stabilizer? So I think we went through this already. So basically, it has to prevent you from going from one extreme of the mood to the other. So antidepressants are not mood stabilizers, and I was just ahead of myself when I explained that. So let's go into traditional mood stabilizers. So we talked about this already. So we have a couple different types of traditional mood stabilizers. We got lithium, we got anti-epileptic drugs, and then we got our first generation and our second generation. So first generation was like a Haldol, a Prolixin, Thorazine. A second generation antipsychotic is more like the Seroquels, Clozapine, Risperdal, those that we talked about. So lithium is arguably the gold standard of bipolar disorder treatment. As you can see here, it was first used in the 1800s for gout and all sorts of things, even a table substitute back then. In 1970, the FDA approved for treating acute mania. It's actually our gold standard. It's very effective. Unfortunately, you know, when you bring up lithium, sometimes people think of, oh, no, lithium. But lithium is such an effective medication. And one of the things it can help with is suicidal thoughts as well. So some common adverse effects of it is feeling tired, difficulty concentrating. You could have weight changes from lithium, and Depakote is another one that can cause weight changes too. One of the things with lithium is it's a medication that has a small window where it's effective to where it can go into toxicity. So there's a couple of important things to note about lithium that I'll tell you guys. So for example, some of the signs that's going into toxicity is loss of balance, slurred speech, if you're having general weakness or drowsiness, for example. Important considerations with it. So what happens is that, you know, especially now, what the temperature today, I don't know, I'm in Southern California, so I don't know if it was just as hot where you guys are, but here it was 100 degrees today. 100 and very, it was semi-windy, not as windy as yesterday. But if you're on lithium, it's so important to stay well hydrated, especially now that it's getting warmer. Because if you become dehydrated when you're on lithium, it can put you into lithium toxicity. So it's really important, making sure you're drinking, 8 glasses of fluids, preferably water throughout the day, limiting the number of caffeinated beverages you drink, and it can have some drug interactions. So, over-the-counter pain medications like Motrin, Aleve, Advil, ibuprofen is another name of the medications. So what those do actually is they can interact with lithium and push you into a toxicity with it. So if you're on lithium, usually we would want to avoid those NSAIDs, non-steroidal anti-inflammatory drugs like the ibuprofen, Motrin, Advil, Aleve. A safer option with lithium is Tylenol if your doctor says it's okay to take Tylenol. Some people can't take Tylenol because of their liver. So if the doctor is okay with Tylenol, and you're on lithium, it's just a safer option if you had to take something over the counter for pain. If you have flu, especially if vomiting or diarrhea occur, check with the doctor regarding your lithium dose, because if you're losing too much fluids, if somebody gets a lot of diarrhea, you're losing too much fluids, that can put you into lithium toxicity too, which we don't want to have. So those are just some important things to note when you're on lithium. Making sure you stay well hydrated, avoiding certain over-the-counter things. So let's take a look at some of the sleep medications. We're going through these like really quickly. Okay, so let's go through sleep medications. So insomnia signs and symptoms, I think pretty much all of us at some point have had. Do we want to start looking at these? Okay, so we'll go into these questions at the end. So insomnia signs and symptoms. So if you're having difficulty falling asleep, maintaining sleep. So it's important to know, right? Some people may have problems just falling asleep. Some people may have problems falling asleep and staying asleep. So it's important to know that, because when the doctor is going through the different medications, some of them last longer than others. So if you're just having a problem just falling asleep, then they would give you something shorter acting. So it can just help you with sleep and doesn't need to stay in your system for a long time. So there's 3 main sleep medications, Sonata, Ambien, Lunesta, that are we call Z-like drugs. I think you probably heard all of those possibly. So Sonata is the shortest acting. So it's one that, like if you're a shift worker and you just need to fall asleep at a certain point, but you don't have to sleep it doesn't have to keep you asleep, that might be a medication that is better for that. Ambien comes as regular Ambien, and it comes as an extended release. So if Ambien immediate release is not keeping you asleep long enough, then there is an extended release version of Ambien. And then Lunesta is the longest acting. So if you need to keep sleeping, Lunesta is the one that'll keep you sleeping the longest. With those medications though, that one thing that you guys should be aware of is some people sleepwalk and do things, sleepwalk like eating behaviors when they're on those medications. That's not good. You let the doctor know right away if that occurs. There are some other medications that benzodiazepine that's used to help with sleep is called Restoril. There is a over-the-counter sleep medication called melatonin. And for some people that works really well, and for some people it doesn't work at all. But it is like a good over-the-counter option that is available. Some people say they take Benadryl to help with sleep, but Benadryl, which is the antihistamine, if you take that every night, it stops working. It's not a good option for long-term for sleep. So if we go back, so one of the first things even before we think about medications is we need to think about what is the reason behind having the problem with sleep, right? So we just talked about mood stabilizers, and we talked about how they can be used for bipolar disorder, right? So in bipolar disorder, it's completely different, where one of the first symptoms of somebody may be going into a manic episode is the decreased need for sleep. And in bipolar, it's like, not only are you not sleeping, but you feel like you don't feel tired even not sleeping for 2 days. So somebody could be up for 2 days or 3 days in a row and not feel tired at all and still feel like they want to keep going. So it's a completely different type of reason for the having problems with the sleep, right? So we're talking about this is a separate issue. This is insomnia. So we want to look at what are some of the causes that could be pertaining to it. So just take a look at some of the etiology and risk factors. 55 to 60% of patients are female that have insomnia, and maybe as high as 2 to 1. It could be related to environmental factors such as noise, light, extremes of temperature. So think about it. If it's really hot in the room, are you going to be able to sleep? Probably not. That could be what's causing the problem with sleep. So if you have the light on, that could be, disturbing your quality of sleep. I can tell you that if I leave the light on versus I have the light off, it's a completely different feeling for me when I wake up in the morning in terms of how rested I feel, or if I was able to fall asleep. And then noise can be another factor as well. Situational stress. So, taking our worries to bed with us can be a risk factor or etiology for sleep. So looking at some ways of maybe relieving stress before going to bed, like doing mindfulness or meditation or something like that. Just not working out too close to bedtime, because that will actually keep you up. That's the opposite. So if that takes us to stimulus control. This should be the first thing we look at, is what are some ways that we can help with problem sleeping. So having regular wake and sleep times. So for example, I knock out right around like 9, and then I wake up at like 5 or 6 in the morning. So that's my sleep schedule. But so keeping that schedule will help. And then for me, like for everyone, there should be only 2 things you do in bed. One of them is sleep, and the other is intimate relations, right? So you should not be sitting in bed on the phone reading, on your phone looking up on things on the internet, reading or watching TV. Because what you're doing to yourself at that point is you're training yourself to be awake and doing these other things when you're in bed. So if you go to bed when you're tired and then go to sleep, it trains you that, hey, as soon as you're in bed, it's like this automatic stimulus that I'm going to go to sleep. So that takes us to go to bed only when sleepy. So avoid long periods of wakefulness in bed. Use the bed only for 2 things. So we just talked about that. We want to avoid trying to force sleep. So if you're not able to fall asleep, because we don't want to just stay awake in bed, because that's what we're going to train ourselves to do. So get up to 20 to 30 minutes. So if you're not falling asleep within 20 to 30 minutes, leave the bed and do something relaxing. And then don't fall asleep though out of the bed. So when you're starting to feel drowsy again, get back into bed. I don't want you guys falling asleep out of the bed. So avoid any kind of light from TV, smartphones, tablets, and other things. I can tell you, like, I've left the TV on a couple times by accident, and then like sometimes even what's on the TV has been coming into my dreams. So you can tell that I'm not having a restful sleep because that noise and the light is bothering me while I'm sleeping. You want to avoid daytime naps because they can affect your ability to go to sleep at night. And I think we already talked about number 7. So we'll move on to the next thing. So do not exercise you want to exercise, but not close to bedtime. Avoiding temperature extremes, so not too cold, not too hot. We want to reduce the amount of, so caffeine and nicotine are stimulating, right? But alcohol is a depressant, but it can actually affect your quality of sleep. So you don't want to be drinking close to bedtime either. So reduce alcohol, caffeine, and nicotine. Alcohol, though, if you're drinking every day for a long period of time, it's something you go to detox. That's something you would go into withdrawal and could have seizures. So for somebody who's been drinking every single day for a long time. Avoid drinking large quantities of liquids in the evening, because you don't want to be getting up and having to pee in the middle of the night, because then you're going to wake up and it's going to be hard to go back to sleep. And it's the same thing if you're on a diuretic for blood pressure. make sure you take that in the morning. Don't take that at night, because at night it's going to have you getting up and having to pee in the middle of the night and not sleeping, right? So we talked about treatment options. So we just went over some non-medication things that we can do to help with sleep. Also, we talked about some benzodiazepine, which is Restorol, and then those 3 drugs we talked about: Sonata, Ambien, and Lunesta. The last one is Ramelteon. Ramelteon is just the prescription form of melatonin. So melatonin is available over the counter. But before you guys start anything over the counter, always make sure you discuss it with your doctor first, because you know, even though something that says it's a herbal natural supplement, it could be all natural. They might interact with medications you're on. They could interact with your underlying condition. So it's really important to ask the doctor first if it's okay to use before you start it. Melatonin, for example, at high doses can possibly affect depression. So that's not good. But at the usual doses, it tends to be well tolerated. But always ask the doctor first, and then they can help you with what dose they want you to take and all of that. And we got to be careful with over-the-counter things as well, because sometimes there's multiple different ingredients in a product, which is not good either. And then we talked about our sedating antidepressants. So we talked about trazodone and Remeron as well. So usually if you have a concurrent, you know, with depression, that's a better option than some of these other ones. These medications, Restorol, Sonata, Ambien, and Lunesta, these are all controlled substances. So they can also, you know, as we get older, we get more sensitive to some side effects. So they can actually possibly increase your risk for confusion, for falls. So we need to just be more mindful with some of these medications as we get older. So it's something that the doctor would look at the benefits versus the risks of those different medications for you if you need something for sleep. We already talked about this. So over the counter, we have melatonin we talked about, and the other one was Benadryl, but Benadryl doesn't work if you take it every day. So how are we doing on time?
Hi, I think we're doing well. So it is 8 o'clock, 8:01 right now.
Okay, so I can keep going.
Yeah.
Okay, fantastic. All right, yay. So I have a question. Any quick acting medications to help with anxiety that are not controlled substances? And is there a way to let the audience interact, and maybe if they...
Yeah, I can unmute everyone, if that's okay.
Yeah, that's fine. I just want to make it more interactive. I'm used to like seeing everybody in person.
Yeah.
Okay. So, I don't know if anybody can think of any quick acting medications that can help with anxiety that are not controlled substances.
So let me do that. Let me go ahead and unmute everyone. All right, I think. And if you want to mute yourself, you can go ahead and do that. If you don't have a question to ask, you can just mute yourself. Thank you.
What about the new, what about the CBD? Would that be considered something that could help with anxiety that's not a controlled substance?
So thank you for bringing that up. I was not thinking of CBD, but it's interesting that you brought that up because it's such a hot topic right now. CBD is everywhere, right?
Right.
So I remember even like going into, I think it was like Bristol Farms, and you know, one of the ladies was helping the other and was like, oh, see the CBD thing, and like was showing her, and I was like, no, there's no guarantee that there's no THC. It is so hard, the process, to actually separate out the THC. So there could be a psychoactive component to it. So just with CBD in general, even though it's out there, we don't know if it's really if it's a good option, because if it does have THC, so what I've seen with THC on the unit where I work is that we have people who get admitted for marijuana-induced psychosis, meaning that they're having a first episode because of that marijuana that they're taking it. So THC can have all sorts of effects on our mental health, right? So can it possibly, CBD maybe help with some anxiety? Possibly, but I usually stay like, you know, I wouldn't use CBD because, you know, there's no guarantees that it doesn't have THC. But that's excellent. Thank you for bringing that up. That's excellent.
Sure.
Bring up.
Sure.
And any other ones that you guys can think of?
There are 2 questions in the chat,
Sure.
and I can go over those.
Sure. And let me just, before we do, let me just make sure I answer the question here that I had put on here.
Okay.
So this is one that most people don't think of, because when you think of medications that help with anxiety, we usually think of the ones that help long-term, like our antidepressants, right? But those take a while to start working for anxiety. They do not work right away, okay? And you have to take those every single day, antidepressants, to help with anxiety. So a medication that helps with anxiety that can be taken as needed is hydroxyzine. So the brand name is Visceral or Atarax. I don't know if anybody's heard of that or has tried it or anything, but I had a patient once that in one of my groups was like, the one medication that like changed my life from when I, you know, thanks to coming to this groups was like hydroxyzine. And I was like, hydroxyzine really was the medication that changed it? But yeah, that for that person, that was the medication. And it helps with anxiety within 30 minutes, and it's not a controlled substance. Another medication that can help, that has a quick onset but is not controlled, at least not in California, is gabapentin, which is Neurontin. So those are just some different prescription medications that can be more like a immediate release non-benzodiazepine medication for anxiety. But we can go ahead and go to the chat now.
Okay.
What happened to my question? Our question.
Julie, did you have a question?
We had a question about clozapine.
Yes.
And we wrote it in the email, so I don't know if you saw that. We'd love it if you could respond to that.
Sure. So the question in the email, and I'm trying to bring it up on here, is what can be done to make clozapine more widely used by people with schizophrenia? It is our understanding that this medication is more widely used in Europe than in the US. So, you know, with clozapine, I'll even go back to the history of what I remember with clozapine too, is as somebody who's, you know, dealt with patients getting clozapine, one of the big barriers for us is like, I've had so many patients that could be good candidates for clozapine, but the problem has been, you know, I've been to the doctor, like, let's get this person on clozapine. He's like, no, this person actually has poor follow-up, usually. So with that, they're not going to adhere to the monitoring that's needed to take the medication, even though a lot of people might be good candidates for it in terms of it could really help their underlying condition. Is that if we're not able to get them to come in and get the monitoring that's needed, then they can't stay on it, and then they're going to end up right back in the hospital or worse. So that's just one of the biggest barriers that we see with clozapine in terms of being able to have it more readily accessible for people. And the patient has to agree to doing the blood monitoring, and some people may not want to do that. So those tend to be some of our biggest hurdles with clozapine. The other things we have to look at too is the metabolic and cardiovascular, all of those factors that come along with it. It tends to have one of the worst profiles. So, you know, not all, we might want to look at something else before that if somebody already has big risk factors, if they're already overweight, or we're going to make them gain more weight and maybe have their diabetes or something else. So those are other factors to look at. And it can come down to prescriber preferences too, unfortunately. So some doctors may be more hesitant than others to start Clozaril. So it could come down to the prescriber preferences as well with Clozaril. But I agree with you. It's a medication that it should be more readily available. And maybe one of the ways that it could be more readily available is if we had more resources to help patients, maybe to be able to get resources for them to be able to go in and get the monitoring done, or maybe having somebody go to them and get the monitoring done. So maybe that's some social work aspect that could be involved as well to do that. But that's just not in my scope, you know, I'm just on the medication side, but it is a medication that should be used more than it probably is. So.
All right.
Thank you.
Thank you. I'm going to go over the questions in the chat, and then I'm also going to go over some questions that were sent to us when you registered. So the first question in the chat is, if genetic testing shows that you're deficient in enzymes that break down or digest dopamine, but you also need more dopamine, can you get too much dopamine? Is there an antipsychotic that may be better other than this situation?
Okay, so let me get this straight. If you're deficient, is that what the question was?
Yes, if genetic testing shows that you're deficient in the enzymes that break down or digest dopamine.
Okay, and then so you're deficient in dopamine, but usually, so what condition are we looking at though?
So the question is, if you're deficient in dopamine, but you also need dopamine, and can you get too much dopamine?
Can you get too much dopamine?
Yeah.
So let me just backtrack that. So dopamine does different things in different parts of the brain. There's actually 4 different dopamine pathways. I had a slide on it, but I took it out. I didn't want to get that technical, but in order to answer this question, I guess that's where I'm going to start. So we have 4 different dopamine pathways. So one of them is called the mesolimbic dopamine pathway. In that pathway, if you get too much dopamine, that's where you start, you know, getting symptoms of psychosis. So you're, like, for example, seeing or hearing things that are not there. And that's where we usually try to have antipsychotics. We want the antipsychotics to go into that dopamine pathway and block dopamine there so that we decrease the dopamine, and that that helps with the hearing things and seeing things that are not there, or maybe some the fixed wrong thought. So also we have other dopamine pathways. So you have the tuberoindenfundibular
This is
dopamine.
a NAMI meeting, Danny.
So with that dopamine pathway, that regulates prolactin. So when antipsychotics go and block dopamine in that pathway, then the prolactin levels are going too high. So that can cause symptoms of women, for example, lactating. It can cause men to get increased breast tissue. And it can cause disturbances and sexual side effects, and problems with differences in menses and stuff. So that's another dopamine pathway we have. We have another one that regulates movement. So that's called the nigrostriatal dopamine pathway. So with that dopamine pathway, antipsychotics that go and block dopamine in that pathway are causing those movement side effects. So if you have too much dopamine in that pathway, I'm assuming you're going to probably get movement side effects as well from that. And then the last one is the mesocortical dopamine pathway, and that has to do with more of the cognition and stuff. So you can get cognitive side effects. So it's kind of like a loaded question where it depends on, you know, if we're getting too much dopamine, which dopamine pathway is it affecting, can cause different types of adverse effects.
Yeah, thank you for answering that. There was a follow-up. There was a question that is, if there is an antipsychotic that may be better in this situation.
So in this situation, and put it on the screen so I can, let me just bring it up. I want to see the question because it is late in the day. I just want to make sure I answer this correctly. Shows that you are deficient in enzyme that breaks down or digests dopamine. What, you also need more dopamine. Can you get too much? Is there an antipsychotic? So I would say if you're deficient at breaking down dopamine, and you're worried about something that's very strong at affecting dopamine, So maybe I'm thinking of this backwards, because if you're deficient at breaking down dopamine, and depends on, that means that you have too much dopamine, right? So it's increasing the amount of dopamine. So in that case, you might want to go for a stronger dopamine blocker. So if I'm understanding it correctly, it might be too late at the end of the day. So if you want, it depends on, depending on their genetics, if you want a stronger dopamine blocker, then you would use something like a risperidol. But depending on the genetics, if they need something that's not a strong dopamine blocker, then you would do something like a Seroquel, if that makes sense. So if you had to do the newer generation, those are like on the opposite ends of the spectrum. So if you need something that's a very strong blocker of dopamine, then the risperidol would be a good option versus Seroquel if you want something that doesn't bind the dopamine as well. It's not as strong. So yeah, I would think about this more, but that's how I would look at it.
Thank you. Thank you so much. Okay, so another question is, why does someone taking clozapine for over a year that stopped has to go through first-year testing frequency increase? It's like punishment for someone on it for over 2 years, but stopped due to relapse.
Oh, so you know, with clozapine, if you've been off of it, so really it depends, and I'm sorry if it seems that way. You know, I don't think that's what they meant. It's more about the safety. So because of that risk for the agranulocytosis, if you've been off of it, they have different schedules that we have to adhere to just to make sure it's safe. And I want to apologize if it's seeming that way, but it's the safety, just to make sure, because you could, you know, if you're starting it, you haven't been on it, that can increase the risk. Or for some, if you've had abnormal values, then they need to, it changes the monitoring schedule. So all of it is just for your own safety, just to make sure that.
I'm the one who asked the question. So is there, in Europe, do they do it that way too? Start you from scratch? Yeah, I'm just wondering if there's someone to talk to try to understand what organization would you talk to? Because it just seems crazy if you skipped it for a month or two, that now you got to start all over again when you've been on it for a long period of time.
So, you know, there is the clozapine monitoring program. That's usually where, you know, it's one REMS and it's one program now. It used to be each manufacturer had their own, but now it's one centralized. So they would have that wealth of information. I mean, I can follow up and give that information to NAMI-Santa Clara. I can look into it for you and give you further information. I don't know what they're doing in Europe specifically for monitoring. I can get you that information.
Thank you. Thank you.
Azita, is it possible to stop sharing the PowerPoint presentation so we have a view of the?
There you go.
Thank you.
Okay.
All right. Thank you so much. On to the next question. My daughter takes Lamictal and Diodon at night. Do you recommend her to take a stimulant like Madphenil to make her more energetic, and does this help her mood?
So what is she taking the Lamictal and Diodon for?
Bipolar.
Okay. So usually, like, I don't. And is the stimulant something the doctor recommended?
Well, it's just so, because she's so, you know, like a zombie. So we thought like maybe an add-on. But I observed that it didn't really work. So I'm just asking if you have any experience with modafinil.
I have had patients. I had one patient that kind of switched between the two. would switch between like something like a Provigil to a stimulant, and then like a stimulant like Adderall or methylphenidate-based stimulant like Concerta, and then switch back. So a lot of times, like for example, with the stimulants, if somebody's been on them for a while, they stop working. So even with ADHD, for example, when somebody is on like a Concerta, which is a methylphenidate based, and they've been on it for a while, it stops working, then they switch them to like an amphetamine based, and once that stops working, they switch them back to the other one. In this specific case, if it hasn't, so I guess with the bipolar, is it more, or is she experiencing like what phase of the bipolar? What was the recent episode or anything? Is it depressed or?
Yeah, it's just more, she's just more down, you know, no energy at all.
Okay. So, and when did the doctor start the stimulant?
Oh, pretty, just maybe like a month.
It's been a month.
Mhm.
And have you noticed any difference at all since?
Not really, but the father really is encouraging her to take it. So that's why
Okay.
I was just thinking if it's worth it to even take modafinil.
Okay. So, and which stimulant is she on?
Modafinil?
Oh, modafinil. Okay, not one of the other ones. Okay. So does she have an appointment coming up at all? Because if she's been on it for a month, I assume it's right around time.
Mm-hmm. Yes, she does.
Okay. So I mean, it's been a month, right? If you haven't noticed any difference, I wouldn't stop it. So don't stop anything on your own or anything. But I would bring that up to the doctor and see, you know, is this one worth it? Or if the doctor wants a stimulant, is one of the other stimulants a safer option? I mean, not a safer option, but an option that she could try to see if it works or not.
Okay.
Sometimes you just got to be careful because the stimulants too can kind of push you into that, you know, they're stimulants. So we got to be careful that we don't want to have the highs either in bipolar. But so discuss that with the doctor and let them know if you haven't noticed anything at all, any kind of energy. And then they can look at, you know, is it the dose? Maybe they can adjust the dose. Maybe it's, you know, one of the other medications can be adjusted, but don't ever do anything on your own. So I think they can do that at the appointment. But yeah, I wouldn't stop it on my own or anything. Okay.
Thank you.
And Azita, there was one question that was submitted while registering about Lamictal as well. And the question is, my psychiatrist prescribed Lamictal for me, and I'm worried about all the side effects. I'm 64 years old woman with bipolar disorder.
Yeah. Okay, thank you. So with, you know, usually what we look at is as we get older with some of the medications, we get a little bit more sensitive to them because of a number of different reasons. So the way that we break down medications is usually through the kidneys and the liver, and the way that those work can change as we get older. So for those reasons, like some medications, we just are more careful as we get older. With Lamictal, we're not really worried about the kidneys. If for some reason there's any kind of history of liver impairment, then they might dose adjust the Lamictal. But generally, it's not even on something we call the Beers list. So the Beers list is a list of medications that are potentially inappropriate in the elderly. And I don't believe I've seen it on there, to my knowledge, with Lamictal. So it's generally well tolerated. One of the things you might see is more, the most common side effect with that is nausea that might could occur. It doesn't really have the weight gain that you see with some of the other medications like the lithium or the Depakote. But the big side effect that we watch out for, it's rare, but it's something you should be aware of, is the life-threatening rash that can occur. So the rash is called a Stevens-Johnson's rash. So the reason it's life-threatening is that if it does occur, you have to like immediately. And I think usually whoever gave that question has probably already been counseled and and your doctor probably already went over it with you too, but at any sign of rash, you stop it and you let the doctor know immediately, because it can progress to a life-threatening rash, and that rash can look kind of like, it could be like the skin, like kind of like burns, or sometimes it can affect organs. So it's really important to like look out for any signs of rash when you're on that medication. So that's the big thing with Lamictal.
Thank you.
So I don't think there's anything specific to the elderly with that or anything.
The next question is, there are some blood tests that can help determine if a medication can help a specific client. Are they in use now?
Okay, so genetic testing. So there's actually been quite a thing. It's a field of pharmacy called pharmacogenomics. You know, the way that we break down medications is, you know, a lot of through these things we call enzymes. So enzymes break things down, right? And based on our genetics, some people may break down medications different than others. So, for example, based on someone's genetics, if they're not able to break down some of the medications, they might be experiencing a lot of side effects with like everything they're trying, right? So that might be a clue, like maybe genetic, if I'm having a side effect and I can't tolerate anything, then maybe genetic testing might be an option. Or if nothing's working for me, then genetic testing might be an option. So I can tell you guys, it's kind of a mixed thing, because from what I've seen from patients, in a lot of cases, even though they've, you know, thought that, you know, they fit either of those categories, they got the genetic testing, it didn't really help them. And it could be really expensive. So I don't want you guys to, you know, waste money. If it's something that you're, you know, if you qualify for and your insurance covers it and all of that, then it might be. But if you have to pay a lot for it, I don't know if it's going to be beneficial for you, because like I said, from people that patients that I've had, not a lot of them have, they've gotten it done, but haven't really had much outcome from getting it done, basically, meaning it hasn't really impacted their medications. So I don't know if anybody on the call wanted to share either if they've ever gotten genetic testing, but that's just been my experience from the patients, and it could be really expensive.
Thank you. One question was, what is the value of injectable medication versus oral medication?
Oh, fantastic question. So, you know, and I know we had quite a few questions about, you know, a lot of times, you know, patients may, there could be, you know, lack of insight into someone's own condition, right? Yes. So because of that, you know, someone may not take their medications, or just in general, if you know, even if you have the insight, meaning you know that, you know, I need to take medications, you could forget them. So you know, we have our oral medications, but you know, if you don't actually take it, it's not going to work for you, right? And then with antipsychotics, even missing a few days of medication can cause relapse, meaning as few as a couple days, you can relapse and be in the hospital. So being compliant with the medications is very important. So a lot of times in the hospital, in the unit that I work on, if a patient is in the hospital because they forget to take their medications, that's the first thing we go to is say, you know, have you thought about a long-acting injectable? Because most of the long-acting injectables stay in your system for a month. So you get the shot every month, right? Instead of having to take a pill every day, it's a shot every month, and then you know it's there, right? So that's an option that could save somebody from ending up back in the hospital and keeping them feeling well. So medications that are available as long-acting injectables. So we have Abilify, comes in a couple different versions, Abilify Maintaina and Aristata. There is Invega Sustaina, which is a once-a-month injectable version of an Invega. And then there's also Risperdal Consta. Risperdal Consta is every 2 weeks, but Invega is just like Risperdal. So, and it's a once a month. So Invega is the one that we do at my hospital instead of the Risperdal Consta. And then there's also Haldol, Decanoate, and Prolixin. Those come as long-acting injectables. So there is quite a few of them. And it's not just limited to antipsychotics. So for anyone that, for helping with cravings for alcohol or opioids, there's a medication called Vivitrol. It's a long-acting injectable version of naltrexone, and that helps to abstain from alcohol or opioids for someone that has cravings for those. So there's different medications that come in long-acting injectables, but for antipsychotics, we have a lot of antipsychotics that do come as long-acting, and they can definitely help someone to keep them from out of the hospital.
Thank you. I have one last question, and then if you do have more questions, feel free to email us, and then we can pass it on to Azita. So the last question is there a way to tell the difference between marijuana-induced mania psychosis and bipolar?
So I do not diagnose. So I don't want to even go down the diagnosis. It's out of my scope to diagnose. But to my knowledge, we know when they come in, they've just had marijuana, and usually they end up giving them something like a Haldol, and then so the doctors rule out substance-induced conditions. So if you're on an illicit substance or something like marijuana, it can actually cause psychosis. So they look at those things when they're trying to do their differentials. Yeah, but it's out of my scope to go into like very specifics about diagnosis. So.
All right, I think it's 8:30. And I do see some questions. What I'm going to do is I'm going to send these to Azita, and then she can answer those. But we have recorded this general meeting, and it would be available, the presentation, the slides, it's going to be available on our website. So thank you so much, Azita. Thank you so much for presenting and giving us all this important information. I think it's very, very useful and very, very informative. So we really appreciate you coming in tonight and presenting and sharing all your knowledge with us. Thank you everyone for joining us tonight, and we will see you again soon. So,
I wanted to thank everyone for attending. I know we didn't get to all your questions. And you're going to email those to me, right? Because I want to make sure I get back to them. Maybe we'll post the answers, or you'll email out the answers.
yes,
Just so that I want to make sure that everybody that did have a question gets their questions answered.
absolutely, absolutely.
And
Yeah, I
I
have some questions in the chat as well that I'm going to send it to you.
Okay, sounds good. All right, thank you
Thank
again.
you. Have a good night, everyone.
Thank you.
Bye, thank you. Bye, everyone. I'm sorry I didn't get to see you in person.
Another
Bye.
time.
Bye. Bye.
Okay.
Thanks
All
again.
right.
Bye.
Okay, got to leave because it's going to close up. Leaving the meeting. Oops, I guess it didn't quite.
I'm just trying to copy before I.
Oh, okay. We're going to leave.
Thank you again for all your help tonight. I really appreciate it. And thanks for having me. So yeah, if you could send that to me, that'd be great. And I'll make sure I answer all their questions.
Yeah, absolutely.